The single takeaway that the president emphasized is that this is something that we're concerned about, but absolutely should not panic about. We have a lot of tools at our disposal, and we will act and react according to when the data and the science come in, and we'll make our appropriate moves according to that. But the president encouraged people to get vaccinated, and those who are vaccinated to get their booster shot, because that will bring up the level of protection against any variant, the way we've seen, just the way it did with Delta. Hi everyone, this is Tony Fauci here, and the president today is going to announce new ways how we are going to address the COVID-19 outbreak as we enter into the winter months, particularly with the new situation that we have now with the Omicron variant. Number one, the president is launching a campaign to get as many people boosted as they possibly can. If you're one of the 100 million Americans who are eligible for a boost, go get your booster shot now. Number two, in order to protect kids and families, we will be launching family vaccination sites throughout the country to make it easier for families, parents, and children to get vaccinated. And number three is free at-home tests for Americans. We will be aimed at getting home tests for American families, free tests where medical insurance for private insurance will pay 100% of the cost to get tests for individuals who need them. Number four, the president is launching 60 surge response teams to help hospitals be able to treat people with COVID-19 disease. Number five, we are strengthening travel requirements in order to make travel much more safe for Americans. Together, these actions will help protect Americans. Go get vaccinated and go.
You know, 10, 15, 20 years ago, and it was for any vaccine that we wanted to make, you would say a vaccine from the time you start to the time it's approved to be safe and effective is several years, 5, 6, 7 years. That's unacceptable for now. So what happened is that as soon as we got the sequence of the virus from the Chinese, we pulled it out of the public database and stuck the gene into a vaccine platform and worked on it literally within a day of when it came out. 65 days later, namely 2 days ago, we gave the first injection to a normal volunteer for a phase 1 trial to see if it's safe. That's the fastest that's ever been done. That's the good news. The challenging news is that even at that rocket speed, it's going to take a few months to show that the initial safety is okay. Then you go into a phase 2 trial, which instead of involving 45 people, which we have in the phase 1 trial, it involves hundreds, if not thousands of people. That will take another 6 to 8 months to even know if it works. So at the fastest we can go, it's going to take a year to a year and a half to know if we have a vaccine that we can use. So apropos of the question you asked me a moment ago, that if we cycle to another season, that's when a vaccine is going to be very relevant. Okay, that's a good question. The initial safety study, Mark, is to see if I inject it in the arm, does it have some sort of idiosyncratic or bad reaction? There's another element to safety, and that is if you vaccinate someone and they make an antibody response and then they get exposed and infected, does the response that you induce actually enhance the infection and make it worse? And the only way you'll know that is if you do an extended study, not in a normal volunteer who has no risk of infection, but in people who are out there in a risk situation. This would not be the first time, if it happened, that a vaccine that looked good in initial safety actually made people worse. There was the history of the respiratory syncytial virus vaccine in children, which paradoxically made the children worse. One of the HIV vaccines that we tested several years ago actually made individuals more likely to get infected. So you can't just go out there and give it unless you feel that in the field, when someone is getting infected and exposed, being vaccinated doesn't make them worse. That's why you got to do a trial. Well, it's a great question because it's exactly happening, and I like the strategy. So there are a number of already approved drugs or drugs that have been developed but almost approved, not quite approved, that are now being looked at because of initial either in vitro or animal data work suggesting that they may be helpful. Give you some examples. There's a drug called remdesivir, which is a drug that was developed by Gilead as an antiviral. We tried it in Ebola. It didn't work as well as some of the other drugs, but it's there. What we're going to do now is there are clinical trials going on right now, both in China and in the United States, to see if it works. It's likely that one or more of these drugs, and there are several, are going to be out there to see an already developed drug if it can work. Another one is interesting. There's a lot of buzz on the internet about this, and that is a drug called chloroquine or hydroxychloroquine, which is a drug that's been approved for decades. Very cheap.
Yeah, it's the old malarial drug.
Yeah, used in malaria and used in certain autoimmune diseases like lupus. There's some indication in the test tube that it might have some activity. The FDA said today that they are going to see if we can do some expanded use access, getting people who might want to use it off label, namely since it's an approved drug. So your point is extremely well taken. One of the immediate ways for treatment is to look at drugs that you want to repurpose. While you're doing that, you want to start developing drugs de novo that are specifically targeted to the coronavirus itself. Those things will go on simultaneously. Well, I think the long-term strategy besides the drug, you have to go with trying to get a vaccine that's really effective. I mean, the history of viral diseases is that if we can get a vaccine, and I'm thinking in two channels, Mark, one, a vaccine for this specific coronavirus, but long-term, just think about it. Since 2002, we've had 3 outbreaks of coronaviruses. SARS, which I mentioned a moment ago, MERS, the Middle East Respiratory Syndrome, and now this novel coronavirus. We should be and are and will be making a universal corona vaccine, which means you can make a vaccine that would be protective against any kind of coronavirus if you get it to make a response that's common to all of them. The same sort of thing that we've been doing for the past couple of years, trying to develop a universal influenza vaccine. To me, that's the best long-term goal for this.
It's not going to be that you're going to eliminate this disease completely. We're not going to do that. But hopefully it will be at such a low level that it doesn't disrupt our normal social, economic, and other interactions with each other. I hope the new normal also includes a real strong corporate memory of what pandemics can do. So we don't just go on when we get this under control, forgetting how we have to do better in both the scientific preparedness, the public health preparedness, and the public health response. New normal, I believe, will have a much, much greater attention to the capability of respiratory viruses to spread as they do. I think their new normal will be, I hope, a greater degree of interconnectivity and solidarity throughout the world when we are talking about the possibility of pandemics. I don't think people are going to be walking around with masks all the time. I mean, I think that that's very much out of the question. That's not going to be something that the world will accept as being normal. We really don't want to get into the whack-a-mole approach towards every new variant where it comes up and you all of a sudden have to make a new booster against a particular variant it gets up, because you'll be chasing it forever. So that's the reason why one of the things we are really all pushing for is finding out what the mechanisms are that induces a response to a commonality among all of the different real and potential variants that we're seeing and that can occur. And that's something that I think is a very, very important scientific goal, to be able to do that. The PCR are highly sensitive. In fact, in some respects can be a bit misleading, because you could recover from the acute phase and not have replication competent virus. And since the PCR doesn't tell you whether it's replication competent, it tells you have nucleotide fragments there. On the other side of the coin, the antigen tests are less sensitive if you give just one. But if you can do it in a sequential way, they become cumulatively as sensitive as a PCR. But there are considerable numbers of false negatives when you have a less sensitive antigen test. So you have two ends of the spectrum.
States. People should not be walking around with masks. There's no reason to be walking around with a mask.
The state government's advice on wearing face masks is in line with the World Health Organization. Under its guidelines, masks should only be worn if you have a cough, fever and difficulty breathing, or if you are healthy and taking care of someone with these symptoms, and or someone with a confirmed case of COVID-19.
If you do not have these symptoms, you do not have to wear masks, because there is no evidence that they protect people who are not sick.
Clearly, if you look at the data, it diminishes respiratory diseases. So it is conceivable that as we go on a year or two or more from now, that during certain seasonal periods, when you have respiratory-borne viruses like the flu, people might actually elect to wear masks to diminish the...
Let me be very clear, and I'm sure the physicians who are up here will reflect this as well. The average American does not need to go out and buy a mask.
Should you wear a mask if you're healthy?
No.
Government officials say face masks are not necessary if you are healthy and don't entirely provide protection against the coronavirus.
Masks do not work for the general public in preventing them from getting coronavirus.
Right.
If you do not have any respiratory symptoms such as fever, cough, or runny nose, you do not need to wear a medical mask like this one.
And if you're not sick, you shouldn't be wearing a medical mask. But if you are, then you should.
We recommend that people who are sick wear a mask. We recommend that people who are around someone who's COVID positive wear a mask, but do not recommend that the general public wears masks as a protective mechanism.
WHO recommends that the wearing of a mask by a member of the public is to prevent that individual giving the disease to somebody else. We don't generally recommend the wearing of masks in public by otherwise well individuals because it has not been up to now associated with any particular benefit. It does have benefits psychologically, socially, and there are social norms around that, and we don't criticize the wearing of masks and have not done so, but there is no specific evidence to suggest that the wearing of masks by the mass population has any particular benefit. In fact, there's some evidence to suggest the opposite in the misuse or wearing a mask properly or fitting it properly or taking it off and all the other risks that are otherwise associated with that.
One mask at least, but if you want to really be sure, get a tighter fit with the second mask.
So wait a minute, are you a double masker, Dr. Fauci? It looks like you are.
President-elect Joe Biden does it. Mitt Romney double masked during the Capitol insurrection. Tom Cruise also double masked.
The new White House press secretary wore the same just today, and doctors say they're onto something.
Doubling up may be one of the safest ways to stop the spread, as many Americans desperately wait for their shot at the COVID vaccine.
Now, Virginia Tech researchers found that doubling up these cloth masks increases the efficacy from 50 to 75%. A 3-layer mask could block up to 90% of the particles.
So if you have a physical covering with one layer, you put another layer on, it just makes common sense that it likely would be more effective. And that's the reason why you see people either double masking or doing a version of an N95. Anyway, so let me just go on about NIH lifts funding pause on gain-of-function research. So let me explain this a little, because whenever this comes out, there's always the pushing back and forth from the press. So like NIH now is going to do dangerous research. No, actually, as a matter of fact, it's exactly the opposite.